But like the amount of people that come in, they're like, well, I've got this orthotic. Well, I've had, you know, injections left and right for this plantar fascia pain. Oh, I've got great toe arthritic changes, so I'm gonna have to go in and have surgery. And you start assessing these things and you start moving up the chain. Like think outside the box, right?
Yeah. Yeah.
You and I both have a similar mentor. Like we were always taught by this mentor who was taught by another mentor is like think outside the box.
Yeah.
Everything's connected for a reason. And you start moving the lumbar spine and you look at these baselines and people's jaws just drop. They're like,
Yeah.
I've had three courses of injections to the plantar fascia. I've had eight pairs of orthotics. I've had all this therapy for 2 years, and you teach me one exercise, and I move my back 40 times, and all of a sudden, like I could jump again without any pain.
Yeah.
It's pretty cool.
It's very cool. And I have had some really cool cases where patients will come in specifically pointing to their heel. No, no pain anywhere else.
Yep.
And they'll be like,
Yep.
and I think there's certain things in the history and how they're moving that can kind of lead you in that direction. Do
Sure.
you have, what are your thoughts there?
Yeah, 100%. So like when I'm looking at a patient when they first come in the door, I'm looking to phenotype them or classify them. And I utilize the McKenzie Institute's classification system. So with that is I'm looking for the most common thing to walk into an orthopedic um, office is what we call a derangement. And the basic definition of a derangement is it's a joint problem that is healthy and there's a loss of motion and there's a rapid improvement when we find its directional preference. And directional preference basically means which can I move that joint in a direction that increases range of motion and decreases symptoms. So if we find a directional preference in that joint, we know we're dealing with a derangement. And the cool thing about a derangement is it is a rapid improvement very
Yeah.
quickly, and it lasts. The second most common, interesting enough, is talking about lower extremity stuff and low back stuff. The second most common thing to walk in the door of a classification is what McKenzie used to call other. And other is basically broken down into the different pain cycles now. So it's quote unquote chronic pain. So there's a lot of social emotional stuff that walk in the door. And we found in the research that we did back at the Rehab Institute of Chicago that in an outpatient physical therapy clinic, 38% of patients walking in the door with musculoskeletal problems, 38% of them are actually brain dominant pain.
Yeah.
So conscious affective, unconscious affective, central sensitivity, whatever it is. So now we look at that number and we're like, man, can we have a foot and ankle problem coming in? Number one, is it the foot and ankle? Or is it the lumbar spine? Okay, if it's not the lumbar spine, we also know that 38% of people walk in the door, it could be burning down. So how the hell do we figure that out? So it's too often in the orthopedic world, in the physical medicine world, is like we look at images, right? And we
Yeah.
could pull up anybody's X-ray MRI of the foot and ankle complex. There's some arthritic changes here. There's some of this going on here. There's some wear and tear to the plantar fascia. But are we really dealing with the right problem, or is that just an incidental problem?
Right.
So we have to zone in on it. And so in the history, what I'm looking for is like number one for a foot and ankle complex is if I'm looking for a derangement, I want to know number one, how long the condition's been present. Right. So if they say it came on 3 weeks ago, I know it can't truly be. I'm going to use plantar fascia as an example.
Yeah.
It can't be plantar fascia because plantar fascia in the books really has to be around for 6 or 8 weeks because it's a it's a remodeling of the soft tissue. And if we look at the pathophysiology of the soft tissue for a dysfunction, it's got to be present for 6 to 8 weeks to create that scar tissue to be a dysfunction. Okay. If it's not that, and if it's there less time than that, I more than likely know I'm dealing with a derangement. Now, my next question is the location, where is it coming from? So constant or intermittent is the next question in the back of my head. Is this constant or intermittent? If I know it's an intermittent symptom, now dysfunction's back in there if they hit the time frame. So there's 4 or 5 questions that really drive it. Number one is how long has it been present? Number two is it constant or intermittent? And the most important thing is what makes it better or worse.
Yeah.
Many times, I mean, think about the amount of times when people come in with foot and ankle complex and they're like, what makes it worse or what makes it better? How are you during running? Oh, I feel great when I run.
Yeah.
Well, when does it hurt? It hurts after my run, but they associate it with running.
Right. Or
right?
like
Well,
it gets worse when sitting on an airplane.
yeah, it gets worse when I'm sitting in an airplane, or, you know, especially with the endurance athletes, is happens after. Well, when I'm done and I'm sitting and getting back in my car and I'm driving back home, or when I'm stretching my hamstrings, or when I'm doing this, or when I'm sitting on the couch. So to me, I'm thinking, okay, if it's a foot and ankle complex, it should be getting worse with more load on it,
Yeah.
right? With if they're running, if that's their problem, not when they're unloading it. So when they're unloading it, what are they doing? What is going on up the chain? Well, their lumbar spine's in probably more flexion, or the lumbar spine's doing this. So now I start looking at the lumbar spine a little bit to tease that out.
So when you do your assessment for
Mhm.
directional preference, can you explain that a little bit of what you do there?
Yeah, I mean, I'm looking for so for the foot and ankle, I would look, let's start there. Foot and ankle, I would look at I'm comparing left to right, the amount of dorsiflexion there is, the amount of plantar flexion, inversion, eversion, and then I could even tease it out and go down to the great toe if I have to. I could go to the second toe, the third toe, whatever joint it is I'm looking for range of motion and comparing it. And
You're not
typically when
just
we
doing, sorry to interrupt. So when you're
no,
talking this directional preference, you're not just talking lumbar spine directional preference. You're doing every joint.
well, if I'm dealing foot and ankle,
Yeah.
I'm taking baseline at the foot and ankle for directional preference. I'm looking at their movement. After I get that baseline, I then go up to the lumbar spine and take that baseline. I don't want to look at the lumbar spine first and God forbid if I move the lumbar spine in extension one time and it could change the distal baseline. So I want to gather their chief complaint baseline first and then go look at the lumbar spine and see what the lumbar spine looks like. If I find an obstruction to movement in the lumbar spine, I'm going to say, hey, listen, Mrs. Smith, our research shows that about 30% of the people with isolated foot and ankle pain have got some lumbar components going on. You've been dealing with this problem for a long time. You've seen 10 chiros, 15 PTs, blah, 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 blah. Would you mind if I spent 15 minutes looking at your lumbar spine to see, just by moving the lumbar spine, if there's a change that happens in the foot and ankle? Well, anybody in the right mind is going to be dealing with symptoms that long. Be like, sure, go for it. So I'll then look at the lumbar spine and I will move the lumbar spine into its most obstructed movement most of the time and see what happens to the symptoms. And I'm always asking while they're moving the lumbar spine, what is happening to your most distal symptom, Mrs. Smith? Well, I don't feel my foot pain anymore. Okay, well, let's keep going with this. And then after about 40, 50 reps, I'll have them stand back up or sit back up and I'll test their range of motion at the distal extremity again. If all of a sudden I see a huge increased range of motion where it was obstructed and I haven't touched the ankle, got to be coming from the lumbar spine more than likely because I haven't moved the ankle at all, or the foot complex at all. And then I test their function. If they weren't able to load it properly, if they weren't able to go into end range dorsiflexion in a loaded position, if they weren't able to jump, all right, can you try jumping now? Holy shit, I'm jumping for the first time in 2 years without pain. How'd you do that? It's coming from the lumbar spine more than likely. So what we like to call it a baseline test recheck baseline.